Lara Briden. Thank you for joining me. You have over 25 years of experience with your clinical practice and even as a researcher, and you've dedicated your time, your professional career, helping thousands of women with this empowering information. So I am so grateful to have you with us to dive into our conversation.
Yeah, I'm excited to be here, Chris. Thanks for inviting me.
Of course. Now, with all of your years of practice, really dedicated to empowering women with information that can really help us understand ourselves better throughout the different life stages we're going through, with where do you think today in our conversation is most urgent for us to understand about women's health?
Yeah, it's a great starting place. So I'm one of my taglines is I'm a cheerleader for women's hormones, both estrogen and progesterone. They both have special powers. They're not just for making babies. They are for that, but if you want to make babies, but not everybody does that. So they're also very important for the brain and the muscles and metabolism and the immune system. And I think one of the sort of gaps in knowledge that's out there is just the understanding that the way we make our hormones is on with a natural monthly cycle or ovulation. So men are quirky in that they make their testosterone every day. It's a bit weird. We make ours in a monthly cycle. So of course that then feeds into some of my other writings and some of the concerns I've expressed about hormonal birth control that really shuts off ovaries and shuts off hormones and yeah, essentially through my lens anyway, robs women of a very important part of our physiology.
Yeah, I'm so glad you started with the hormones. It seems like hormones are really at the heart of like the different stages and how we kind of shift through our lives. So, and especially when you just mentioned, it's news to me the fact that we make our hormones during our cycles.
Yeah.
And obviously, women are going to go through stages, and I feel like I'm in my perimenopausal stage, but can we zoom out a little bit and first of all, walk us through the major kind of hormonal shifts that
Yeah.
every woman will go through and how we can better understand what is happening in those stages?
Yeah, for sure. Great. Another great question. So again, as that's something I explore a little bit in my third book, my metabolism book, I talk about the different modes of being females. So again, men are quirky in that they've really just kind of got one mode. They had childhood, then
So
puberty,
easy.
then boom, they're in testosterone mode and that's pretty much it. And whereas for women, I mean, I think, and again, I would frame female through my background as a biologist, actually, I frame female as the standard normal version of biology. So I think male is quirky. I mean, it's mostly a joke, but like both are normal. It's not like the male version is normal, but female version of physiology, there are different modes and the different phases, if you will. But certainly there's the same, childhood, puberty, and then throughout our reproductive lives, we have the different phases of the menstrual cycle. So at every part of the month, hormones are quite different. Just a fun fact that people might not know is during the early part of the menstrual cycle, during the bleed,
Yes.
both estrogen and progesterone are very low. Estrogen is at menopausal levels for a few days at that part of the menstrual cycle, and that's totally normal. It actually feels quite great, actually, for estrogen to go that low. As a lot of women know, they feel pretty good during their period often. And then other modes would be pregnancy. If people have pregnancies, women have pregnancies. Then postpartum is a transition phase. Motherhood itself, biological motherhood, is actually changes the brain. So there's lots going on hormonally with all of that. And then, as you mentioned, perimenopause, and perimenopause itself has different phases. So there's like a very high estrogen phase of perimenopause, and then the lower estrogen phases, and then menopause or postmenopause, which is at least 1/3 of our lives if we're lucky enough to live to 80. no, and this is the thing. These are phases we all go through if we're lucky enough. So it's a gift to privilege to actually get to go through menopause and live that long. Um, and one thing I would say about menopause, so my second book, Hormone Repair Manual, is all about this. It is a normal life phase. So it's both. I mean, I think it's totally okay to take estrogen therapy for menopause. I mean, I do actually myself, so I'm happy to disclose that. But at the same time, through my lens as a biologist, humans evolved to have menopause. We evolved to spend a big chunk of our lives in a low hormone, low estrogen state. That is not a deficiency. And the reason I say that is there is a strong kind of narrative out there pushing that it's somehow a deficiency, like equivalent to having a thyroid deficiency or something, or that is not correct from a scientific perspective. It really is not. We are, human physiology is, well, I would say designed, evolved for this. It's more than that, actually. There's evidence that potentially a longer human lifespan for both sexes evolved under, I don't, this is too technical, but positive selection pressure for a long post-reproductive lifespan in women. So menopause, all those decades in menopause or post-reproduction were very beneficial to our ancestors potentially. We know that from modern day forager people, where women in their 50s and 60s and 70s, even in these quite traditional lifestyles, get a lot done. They gather
Yes.
more food than anybody else. They keep it all together. They hold it all together for the group. And that's been like that for a long time. And so menopause is not an accident.
I love so much about your messaging and what I gathered, even the way your tone in your books, because it's so empowering. And like you said, that there is this stigma, and you're right, and it's a shame. And I feel like a lot about what we women and even young girls, because I remember even like during my adolescent years being on my period, like just the narrative around like the teenage years with the girls, it wasn't of something to feel proud about and excited about and empowered about. I mean, if I remember, it was feelings of kind of embarrassment or an
Yeah.
inconvenience or an I'll admit, it's a little shameful, but up until even like recent years, I felt like being on my period felt like icky. I didn't feel
Mhm.
good about it. And that's why I love the way you are sharing the message, is that there's absolutely nothing wrong. There shouldn't be any shame. It's not even a deficiency.
Mhm.
Unfortunately, there's been bad messaging, even in the medical field. And I even found it interesting because I was doing more research and listening to a lot of your content and other people's content who are focusing on women's health,
Yeah.
that apparently even in the allopathic medicine and studying medicine, women who went into either OBGYN or being a physician, there wasn't even dedicated like enough like research or practice to really understanding our physiology.
Yeah. I mean, there has been a gap. I saw this great quote from, it was a beautiful quote actually from her name is Lisa Mosconi. She's the, people probably know her name. She's big. She's a neuroscientist who's researching how hormones affect the brain and menopause and brain. And they had this great quote is like, science owes women a century of research, which was just quite a beautiful way to phrase it. Like there's been a gap. The gap is improving. And I actually think it has improved somewhat, but yeah, there is kind of a startling lack of attention to certain things. And yeah, but hopefully that is changing as more women like Dr. Mosconi and other just diving down into things that we should have known about a long time ago. I mean, for context, there's still actually a lot about the human body in general that we don't understand. So
Mhm.
yeah, what we don't know about the female body is part of that as well.
Understand. Yes, you're
Yeah.
right. Thankfully, we are in a better place now and empowering more women. So earlier during your points about our hormonal shifts and how
Yeah.
important it is, you mentioned how we actually make our hormones during our cycle. And
Yeah.
in one of your books, you mention, I thought this was even illuminating for me. I didn't understand, but is this why you say ovulation is so crucial for our overall health,
Yeah,
even if you're not wanting to get pregnant? And that's definitely someone like me, I'm in that cohort.
sure. Yeah, great. I love that you've read my books. I can tell you've read my books. That's very, I mean, I know, I mean, fair enough. Not all interviewers have actually read my books. So it's like, that's great. Yeah, that's sweet. So, yes, ovulation, regular ovulation is how women make hormones. So it is very much important for general health, not just to make a baby. A regular ovulation, so ovulation is when the ovaries release an egg, but it's also the main hormonal event of the menstrual
Wow.
cycle. It's the main thing that the ovaries are doing. And the whole reason a menstrual cycle is monthly is because that's approximately how long it takes, to build up to ovulation and then ovulate and then have the 2 weeks after ovulation where a special gland forms. And so I'm a cheerleader for women's hormones. I am a cheerleader for ovulation. I've been very much influenced. So certainly I think my influence has come from a biologist first, evolutionary biologist. So I see everything through that lens. Once a biologist, always a biologist, I think. And then
Mhm.
my work in natural health, but also I'm very closely connected with a scientist named Professor Geraldine Pryor, who some of your listeners might have heard of. She has also been a champion for ovulation for about 40, 50 years almost. She's published over 100 papers. Her group of scientists and lab have focused, and she's still doing science, even though she's in her 80s, have focused on highlighting ovulation and the importance of that for bone health, for brain, for immune system, all the things. And obviously, we only ovulate up until a certain point. So, of course, I mean, ovulation does end around age 50. So but that's factored in. What happens is, during those reproductive years, we build up what's called metabolic reserve.
Mhm.
The presence of those hormones helps to sort of create a solid foundation for health, so that even once we enter into the lower hormone phase, um, that should, in lots of ways, sort of hold us for the next 30 years.
Got it. Got it. Is
Yeah,
that also why, because it's so important for us to make our hormones during ovulation, or why ovulation is such an important, healthy marker of our women's health? Is that also why you've been so outspoken about the overprescription of birth control pills, because it impacts our ability to create these hormones?
exactly.
Are,
Well, so we've been in a situation, I call it, the era or the epoch of contraceptive drugs. It's own medication. We feel like it's forever, but it's really only 60 or 70 years. So it's about 3 generations, I guess, 3 or 4 generations where this has become the normal thing to
yeah,
do. And when it first started, it wasn't given to like 12-year-olds like it is now. So, but certainly we're in this paradigm. It's a paradigm where it's ovulation is considered unnecessary until you're ready to make a baby. So the practice is with almost any type of hormonal birth control, not just the pills, but the implants and injections and rings and patches, they switch off ovulation. Almost all of them do. The exception to that would be the hormonal IUD, which we can circle back to. It doesn't actually always switch off ovulation, but most of them do. And it's a weird situation if you think about it, Chris. So, like, this would be the analogy I often give is this would be like saying to men, look, you don't need your testicular function or your testosterone until you're ready to make a baby. So, we're going to give you this medication that turns it off. And we're going to then replace your testosterone with this other medication that's kind of like testosterone, but also a little more like estrogen and not really like any of them. And it has some side effects, but the idea is that'll be good enough. We're just wishful thinking that's going to be good enough for your health. And that's like, if that were proposed for men, I mean, obviously we would just think that is crazy. Like, I actually think if hormonal birth control were proposed for the first time now, it would, back in the 60s, they didn't even really know about like a lot of what we're talking about now, the benefits of estrogen and progesterone, that wasn't really thought about. And so if it were proposed now, I think a lot of scientists and doctors and everyone would just be like, that seems like a bad thing to do. And we are starting to see some studies bear that out. Like we're getting more studies now, for example, that hormonal birth control increases the risk of mental health symptoms. Potentially, it does change the shape of the brain. Um, yeah,
The
giving a contraceptive medication to teenagers seems to actually permanently increase their risk of mental health, even once they stop taking it, which makes sense because, like the researchers in that study pointed out, it's biologically plausible because the brain is very sensitive to hormones. And so if you take away the hormones that are supposed to be there and you put back something that's not really the same molecule at all in a teenage brain, you're likely going to get changes. I mean, we're seeing things like, we know girls don't reach their what's called peak bone density if they're on hormonal birth control. They're not building up that bone that they're supposed to have into their, building into their teenage years. And so for all of us, by about age 25, we have the strongest bones we're ever going to have in our lives. And then that's called peak bone density. That's true for men as well, 25, 30. And then we just start declining from that point. It's normal. I mean, we've got, if we reach a good peak bone density, it should be enough to keep us, hold us until 80, slowly declines. But yeah, that's a concern if girls aren't, there are other things that might prevent girls from reaching that peak bone density. One would be, so one is hormonal birth control. The other is under eating to the point that ovulation turns off, and there's therefore no hormones being made. That's very bad for bones as well. Yeah.
But then I'm just in shock because it sounds scary when it can impact our brain health, our mental health, bone density, and yet, like growing up, so I was in the 90s when I was in college. Anyway, and I felt like every other girl in college was on a pill, whether it was for contraception, or I remember being prescribed the pill even though I wasn't sexually active because I had hormonal acne. And thankfully, I don't know what empowered my own decision making at the time. I think I was only on it for like 2 or 3 months max, but I didn't feel good. I gained some weight and I'm like, I don't need this.
Yeah.
But besides, I remember every other girl in college was on it all throughout my young adult life. All of my friends, every other woman I knew was on it for one reason or another. And hearing from you all the negative consequences it can have on a woman's health throughout her years, like it sounds like, why are we on it? Are there other healthier alternatives?
Right.
Well, I mean, I understand
So,
why.
yeah. So first of all, as you say, a lot of women have taken it over the years. So, I mean, I certainly don't want to like overstate these things. I mean, some of the things I'm talking about are going to be more of a subtle, long-term risk. I mean, I think, and we're still, because it's only, as I said, it's sort of been an experiment. We've really only had it for the last 60 or 70 years. And prescribing it, it's been prescribed younger and younger. So, I mean, probably my generation, was prescribed it at, around 15 years old, 17 years old, like you say, for skin and stuff like that. But now, like a lot of my patients might have been put on it at like 11 or 12. That's kind of new. So we're going to see, the science is going to have to sort of track it and say what happens to these girls, like what is their longer term risk of bone health, metabolic health, heart health, and brain health as well. I'd be curious to see sort of long term what this translates into for dementia risk. So for example, there just was, and science like that takes a long time, so there was just actually some fairly recent research which we could put in the show notes. I could find this for you, finding that women who had regular ovulation, so natural ovulatory menstrual cycles in their younger years, have a reduced risk of dementia long-term from association, which makes sense actually, because it could just be an association. It could just be they were healthier generally, and that led to both healthy menstrual cycles and healthier brain later in life, or it could be that all the hormones they were making from those menstrual cycles helped support brain health later in life. So those are some of the kinds of studies we're going to have to start to look at to assess long-term risk. I mean, reassuringly, obviously the things that have been tracked and people have been watching are, in terms of hormonal birth control safety, have been things like cancer risk and blood clot risk. And so big picture, those risks are relatively small. As you know, there is a blood clot risk with many types of hormonal birth control. That's been known for a long time. It is a small risk, but it's quite a devastating one for those, women who are affected by and die from it sometimes. And also we do know that all types of hormonal birth control, including progestin-only methods, including like the hormonal IUD, carry a slight increased breast cancer risk. So they all slightly, I don't know I forget the exact number, but it's not a strong risk. But I mean, that just gives you a sense of the what science has to grapple with to try to track when hundreds of millions of women around the world take these medications, and trying to track what that's like over time, and what we're actually seeing effects from that. Some of it's just speculation because, as I said, we know, like, on the one hand, we know natural hormones, or the hormones we make, are beneficial. So then logically, like, removing those hormones is likely going to have long-term effects, but we don't have all the data on what that's going to look like. As one thing, just to illustrate though, another one of my takeaways from my work is the difference between progestins in hormonal birth control, which are the synthetic versions of progesterone, and real progesterone that our body makes, or that you can take as a type of hormone therapy, natural progesterone. All progestins, just to compare and contrast, all progestins slightly increase the risk of breast cancer. Progesterone probably reduces the risk. So that's a stark kind of compare and contrast between the
natural versus the synthetic version.
Yeah.
Got it. And we make progesterone naturally in one of their stages of our cycle.
Yeah, the second. Yep. So we have to ovulate. So we make estrogen leading up to ovulation. So the ovaries kind of make estrogen as they're getting ready to ovulate, as they're progressing towards it. And you can have a cycle where you don't ovulate at all. That is not uncommon. That's called an anovulatory cycle. That becomes actually very common during perimenopause. That's the main feature of the early phases of perimenopause, is you're still making lots of estrogen, but not ovulating, so not making progesterone. But in a healthy cycle, in a younger woman, progesterone is the hormone that kicks in after ovulation. It's made by a little temporary gland in the ovary. It's actually what the part of the little follicle that released the egg then turns into a gland that lasts. It only has a lifespan of 2 weeks, so it just pumps out a huge amount of progesterone, like just an enormous amount of progesterone during that time, and then it either is reabsorbed at the end of the menstrual cycle, or if there's pregnancy, then that gland is rescued, and it will keep making progesterone to hold the pregnancy.
Got it. And this is a perfect segue. Thank you, Dr. Lara, to segue into perimenopause a little bit more, if we may.
Yeah.
You also call it the second puberty stage in the woman's life. Why is that? And and you mentioned earlier that there are even different stages of perimenopause. Can you
different
help
phases,
enlighten us through these different stages? Because I know for a lot of women, and as I mentioned, I think I'm going in it, and that's the thing. Like, I think, like, so, and a lot of women, I don't think realize that they may be in it. So how can we, do we get diagnosed? Like, help us walk through this confusing, important second puberty of our life.
Yeah, it is a bit confusing. Unfortunately, it's a bit more confusing now, I think, than it even was 5 years ago, because there's just so much conflicting information out there on social media. I'm sure many of your listeners know what I'm talking about. Okay, so a few things to say about it. I call it second puberty. It's also been called puberty in reverse. It's just, first puberty is obviously the ovaries are ramping up. It's like, okay, here's some estrogen and here's some progesterone in that order. So when we're 12, 13, getting ready, or 11, 12, getting ready to have our first period. First, there's lots of estrogen around, not very much progesterone because the body's just still learning how to ovulate. And that actually can be associated with heavy periods right at the start for some teenagers, and migraines and things like that. That's a symptom of high estrogen compared to progesterone. And then at the other end of the few decades of cycling, progesterone goes away first because, as I said, ovulation starts to not happen a lot of the time. There still can be actually quite a lot of estrogen in those early phases of perimenopause. So the first phase, and each phase lasts a couple years. It really depends on the person, but yeah, in the first phase, it'll be progesterone's kind of dropping away, so periods will become heavier potentially, or migraines will flare up again. Maybe people might have not had migraines since they were like 13, 14. A common thing I'll hear from my patients is they had migraines in puberty. Then they had migraines when they tried to take the pill and couldn't. These are the migraine sufferer people. And then they had migraines again flaring up in their 40s. And then that's usually a sign. That was one of the, I use sort of a list of 9 symptoms that kind of suggest perimenopause. And increased migraines is one of them. Of course, some people don't get migraines, so you can't rely on that one necessarily. But, and then things like heavier periods, breast pain, stronger premenstrual mood symptoms, sleep disturbance is a big one. That's probably one of the first ones for a lot of people, is this, especially people who've always been really good sleepers. And then they're like, oh my goodness, suddenly I'm like popping awake at 3 a.m. and they've never done that before. And that can be very destabilizing in life too, as you can imagine. So that's a symptom. And weight gain would be another one. Yeah.
Sorry, why is sleep disturbance such a big one? Is that again just the impact of the hormone shifts?
On the brain, yeah. I think that is from progesterone dropping away, because progesterone is normally quite a calming hormone that promotes sleep, helps to regulate the stress response system, or the kind of what's called the HPA, adrenal kind of axis. The cortisol adrenaline system in the body is regulated to some extent by progesterone. So when it drops away, and also the sleep centers in the brain, the circadian rhythm is affected by female hormones. So yeah, those are some of the, and night sweats and those sorts of things can start up. But to be fair, not everyone experiences strong symptoms. So this is something that's also worth mentioning, because one of the narratives that's out there at the moment, of course, we hear about from all the women who are having a terrible time, which makes sense because they want to talk about it. But some women really don't notice very much at all. They might just start to notice classically they notice maybe their periods are coming closer together. They're a little bit heavier for a while. And then eventually after a few years, they start spreading further apart, and then having big gaps between their periods. And then, finally not having another period. And some women might navigate all that with very few symptoms. I actually had someone on social media ask me, she was concerned because she'd seen so much about the terrible symptoms of perimenopause. And then she said to me, like, clearly I'm in perimenopause because of my, 49, and my periods are far and few between. She said, but I don't notice anything. Does that mean something's wrong? I'm like, no, that's fine. Like you're just, there's nothing about perimenopause that should be inherently symptomatic. And actually this is the other thing we know from the few people in the world who are still living a very traditional lifestyle. So that one would be the Hadza in Tanzania. They're sort of modern day people, but living a forager lifestyle. They don't report any symptoms with perimenopause. They have menopause. They go, their periods stop around 45, 50. They live into their 60s, 70s. They're, and as long as they can live that long. So of course, in a traditional lifestyle like that, people are more at risk of infection and injury and stuff like that. So fewer people make it all the way through to 70 or 80, but they still do. And most women in those forager groups, the reports that I've read, they're happy about it, menopause. Yeah, they don't notice any symptoms. So that really does say something about that could be interpreted as like a mismatch with our modern world. There's something in our modern environment that is making this transition more symptomatic for women in this society. Yeah. Yeah.
That's exactly what I was going to ask you. Is it environmental
Yes.
factors then? 'Cause that was such a fascinating comparison. The women like in Tanzania more living
Yeah.
the traditional forager life. Wow, I mean, what could be in the modern environment? Are there any specific things that you would probably point to, or is it just like a whole litany, a list?
It's a lot. And I'm sure your listeners right now are already listing a few in their, brains of what it could be. So just to give maybe my top five, it's probably, I mean, it's a number of things all combined, I think. And there's probably some that
Yeah.
we haven't even really thought of. But one would be it is just a different life history. So I have seen more and more scientists talk about how in our modern world, we actually spend a lot of our lives kind of in quite a high estrogen state relatively because we're not breastfeeding for, years at a time. We're sort of because breastfeeding is a very low estrogen. If periods are suppressed by breastfeeding, then that's a time of very low estrogen, like menopausal levels. So traditionally women would spend quite a few years in that. Also kind of a more modern lifestyle, being very active, eating, high kind of fiber diet. And that actually creates sort of a lower estrogen state in a good way. Like, still enough estrogen to go have menstrual cycles and be fertile and everything, but just generally kind of dialing it down. Whereas various factors in our modern world, including probably changes with the microbiome, alcohol, those all, and having more periods, those all increase estrogen, if that makes sense. And so it's addictive. Like if you kind of go through years and years of it, I talk about this in my first book, like the kind of hormonal rivers, as the body gets used to a certain amount of all this estrogen around, then when that starts to change, I think you're going to feel that a lot more strongly. So that's one example. I mentioned alcohol, I think, is a factor because women across the board, all my patients, all my friends, when during those tricky perimenopause years, if sleep is affected and night sweats, without exception, people have said if they stop alcohol at that time, you get a dramatic improvement in a lot of those symptoms. So I think that's part of the mismatch. I think, I mentioned microbiome affects things. There's also little quirky things like it's in my perimenopause book in my hormone repair manual. There's a couple studies. I don't know if they've been followed up on, but where specifically for this kind of last couple generations, so around lead. So I was a kid in the 70s. There was a lot more lead around. We had leaded gasoline or leaded petroleum in cars. It's crazy to think about now. Like, there was lead in this, in the playgrounds, in the paint. Like it was just, I mean, they're trying to obviously, society is
Hmm.
trying to reduce that risk, but a lot of us were exposed. And what a couple of studies have shown, which is very interesting, is that so when you're exposed to lead, the body puts it into the bones as a place to kind of just sequester it and store it away. And then when times of lower estrogen, when you sort of hormonal transition, there is higher bone turnover. That's a definite thing that happens. And so part of the higher bone turnover could be sort of a liberation or like a release of lead into the system, which is a nerve toxin. So it definitely could potentially be part of the aggravation of anxiety and sleep disturbance that some women experience, which is just one of those very interesting thing. I mean, I'm sure it's not the only factor, but if that's a factor, that is directly a factor of environmental toxins. And I suspect there are other toxins that are playing into our perimenopausal situation, converting what should be just a symptomless, normal transition that females go through into something symptomatic. And so the symptoms are real. The symptoms that women experience are real. They're not imagining them. But it's not innate. Like this wasn't our destiny to have these symptoms. It's unfortunately just an effect of our modern life.
So if those women are having these symptoms that are uncomfortable and
Yeah.
disturbing their everyday life, what do you advocate for any kind of natural approach to regulate the hormones throughout this phase or hormone therapy? I have an older friend who said she was on hormone therapy. So what is your stance and what do you recommend?
So my second book, Hormone Repair Manual, is all about this, like all the different ways to feel better. And it's always a combination. It's definitely not an either or situation, because I can say that just hormone therapy on its own without some of the other support is often not enough. I mean, there are people out there, obviously, who are cheerleaders for hormone therapy and sort of say it can fix everything, but it can't. I mean, it can only do so much. So there's always going to be a place for, as I said, like, taking a break from alcohol. Movement is hugely important, like regulating the circadian rhythm, getting outside. This is maybe just naturally why women in perimenopause have this, well, many of us have this desire to just be outside more. That was certainly one of my main symptoms, is like, I need to just get outside, like feel like a kid again. It's like, and so that, and then there's a place for hormone therapy for sure. So in the book and in my work, I do talk about using progesterone, so natural progesterone, as when appropriate. So especially in the early phases of perimenopause, which is a state of high estrogen, low progesterone. So that's kind of a more logical, can very much help with sleep, can lighten flow, menstrual flow. And then for some women, that might be all they need, a combination of, lifestyle things, taking magnesium, one of my favorite supplements, taking some natural progesterone. That can be enough for some women. Some women need more, and especially later phases when estrogen is really dropping to lower levels, then there can be a place for estrogen therapy. It's kind of mitigating or compensating for what I talked about earlier, like, maybe just having had a life of, through no fault of your own, of having had a life of quite high estrogen and then having to adapt to the lower estrogen. Estrogen therapy can play a role in that. I'll just say again, though, like it's fine to take estrogen therapy, and there's different types of estrogen therapy, and like we could drill down into all the different types. Most modern estrogen therapy is what's called body identical or natural, which is body identical estradiol, which is very different than what women were given in the 90s.
Mm-hmm.
So that's good. And it's much safer than older styles of estrogen therapy. But all that said, just to reiterate, the body has mechanisms to adapt to lower estrogen. So it's pretty much expecting to go into a lower estrogen phase of life. And so it's not, again, taking estrogen can be helpful, but it's not correcting a deficiency. Exactly. It's just kind of compensating for, having a tougher time. And also some women just need it for, like, there's so much nuance, I'm sure, Chris, in every topic. It's like, if you start unpacking it, it's like, well, there's this situation and this situation. So yeah, and this. So women who had surgical menopause, had their ovaries removed, they almost always need some estrogen therapy, I think, because our menopausal ovaries still make hormones. They are not useless. They still make androgens, or which is the sort of male hormones and the precursor to estrogens. They make some estrogens. So they're still, even in our menopausal years, the ovaries are doing something. So that's why women without their ovaries, would there be an argument for them to be more in need of hormone therapy? And then there's women who have, we talked about bone problems. Like, so if they are experiencing osteoporosis or like a much more severe bone loss than is normal, then possibly through different smoking or like having had years without periods or something like that, then that would be a reason to potentially also take estrogen. So, yeah.
Got it. So is there a way that a woman can best arm themselves in starting a conversation with their OBGYN in if they are in this stage or think they're in their stage, like starting with like getting a hormone panel, or where can a woman start and lead the conversation with their doctor? And I ask this because, as I mentioned, I still don't know if I'm really in perimenopause. I think I am. I mean, I'm 45, and if I may share, Laura,
Yeah.
I had a very scary incident. No, not one incident. But for the past year, I was struggling and in pain for a year in silence. And thankfully, that's in the past. But it actually took multiple conversations and visits. And finally, one scary incident in Korea to tell my OBGYN, I think this is all related to my menstrual cycle, because it's all happening during the time of my menstrual cycle, either on the first day of the scary incident incident in Korea I mentioned was on the third day. So for a year and a half, I always on my period, I had really heavy cramp pains. And the interesting thing is, I grew up all throughout my adolescent years, all the way up until my early 40s, never experienced period cramps. Never. All my friends looked at me like, who are you? Like, what alien are you? So not until my mid 40s. But the scarier thing is, I've had near fainting incidences on my period, and I was bleeding heavily, like through
Mm.
my tampon, through my panty liner. And the scary incident in Korea, my mom found me fainted in the bathroom floor.
Oh no.
And
Yeah.
yeah, but before then, when I had been telling my OBGYN, like, I'm getting nauseous, I almost fainted, I was even vomiting, and she just kind of like didn't dismiss it, but didn't think anything serious until I came back from Korea, and I was like, I fainted. My mom found me on the bathroom floor, and she's
Yeah.
like, okay, this is not normal. And I told her, I am now scared to walk outside when I'm on my period because I'm afraid I might faint again. She's like, okay, this is not normal. I want you to see a endometriosis specialist. And I basically ended up, they found polyps, endometrial polyps,
Right.
which the surgeon removed. And do you know that now I've been on my period for like, I don't know, a few cycles now? So much better. So
That's
much better. But it took, my point of my story I want to share is that it took a scary incident after multiple visits with my OBGYN. And it's like, okay, fine. This is
right.
not normal. Let's get you to see a specialist. So how can we have this conversation with our doctor to like, listen, I think something is happening to me. Can we not
Right.
dismiss it?
Oh, thanks for sharing your story. Yeah, no, it does. Unfortunately, it does require some persistence. It's good that you ended up, yes, arriving at the correct diagnosis of polyps and they were addressed. So it's all my books do have sections on how to speak with your doctors. So
Mm,
that's it's. I'm trying to help in various situations. Yeah, situations of bleeding or pain. It can help to sort of quantify it too. Like you're just trying to put it into kind of doctor speak, like more scientific terms. So the fainting was obviously a very extreme example, but just to say something like, look, I used to have only need like 8 or 10 tampons through my period, but now I'm like bleeding through, as you said, I'm bleeding through them. I have to change every, hour or two, like sort of trying to quantify it and sort of just say this is different from 6 months ago. And that can help to demonstrate um, what's going on. And yeah, there are other tips in my books of how to speak with your doctor. But in answer to your question, like if the answer, so in your case, you got the answer of the polyps, which was very specific and can be seen on an ultrasound and is, in many ways like a relatively easy thing to diagnose once they looked for them. Perimenopause isn't quite like that. There's no there's no blood test for it. It's actually more just from context and also ruling out other explanations. So it's a diagnosis of exclusion. So if a woman, I listed some of those symptoms before, like, night sweats and sleep disturbance and heavier periods and even more painful periods can just be a symptom of perimenopause. In your case, it was um, something more specific, but um, yeah, so that's what I mean by exclusion. So when those symptoms start to arise, then the
uh-huh.
first part is to rule out other explanations for those. So yeah, do an ultrasound, pelvic ultrasound. Is there other polyps? Is there something called adenomyosis, which is also really common in women's 40s? I kind of thought that's where you were going, maybe what was going to be your diagnosis, but and then obviously rule out thyroid conditions. The doctor should be able to help do all that. And once everything else has been ruled out and it's from context, someone in their 40s having these symptoms, especially if it correlates with maybe the periods getting closer together, which is the classic first phase of perimenopause, then yeah,
Wow.
then it's like, well, that's sort of what it likely is the explanation. I mean, there's no real blood test. The people who can probably pick up perimenopause are if there's anyone listening who tracks their temperatures, tracks their cycles with what's called fertility awareness based method. I'm just giving a plug for anybody like that listening. You can usually tell on these are temperature charts. You've heard about this, right? Like people track their temperature through the month. You can see on the charts when ovulation starts to not happen and you get shorter luteal phases. And that's the classic part. That's perimenopause. Yeah.
So interesting. I really that there's no blood test for it, and it's an exclusion test, and you have to
Yeah.
track all these things that your body, your all these changes
Hmm.
your body is going through. I literally thought that we could just have like a hormone panel test, and you're like, okay,
Not
clearly these
really.
little.
No, it would be so much tidier and yeah, easier if that was the way. Yeah.
Got it. Oh, thank you for that.
Yeah.
I know we only have a few minutes left. I do want to ask you a little bit, one or two questions, if you don't mind,
Sure.
about metabolism health,
Yes.
because I did read through part of that book as
Yes.
well too. And what I found really interesting, that if you may speak about this, but that our hunger is unconscious, and more of an issue with losing weight or adding weight has to do with metabolic inflexibility.
Yep. Yeah. Good
What,
memory. Yeah.
yeah,
Okay.
what is that? Was really fascinating.
Yeah.
And I have a friend who's been going through a process of wanting to lose weight, and I was like, oh my God, I'm reading about like hunger is unconscious, and I'm like, so please enlighten us. What does this all mean, and how can this information be empowering?
Yeah. So we've, again, there's been a paradigm. There's been this narrative that people, you know, are sort of in control of how much they eat and calories in versus calories out. This is sort of like calories in, calories out. If you eat more and exercise less, then the arithmetic equation is going to equal more fat
Yeah.
gained. And that has been it's a very appealing way of seeing it because it all just seems very logical and you should be able to control those two variables. But that is actually not how it plays out. The science is pretty clear that historically, before everything went so wrong in our modern world, again, people were not overweight. They were not consciously, like actively eating less. They were just eating the amount they felt needed to eat and kind of moving the amount, that they just needed to do with their lives. And their weight was just regulating itself. And so there's growing evidence that something has gone wrong. And in the book, I do talk about what, again, it's the modern world. It's like environmental toxins, it's gut microbiome. It's probably, I'll just drop this here, it's probably something to do with vegetable oils, possibly, has dysregulated the system and resulted in a lot of people feeling a lot hungrier a lot more of the time, and this kind of constant gnawing hunger and food noise that people talk about, like it's and this sort of like always thinking about food and sort of getting drops in blood sugar and needing to eat just to keep your energy up. And at the same time, that'll, as I explain in the book, that will go along with, when that's happening, that will usually go along with the body burning less energy, like trying to kind of conserve energy and hang on to energy because the body is not able to tap into its energy
Mm.
stores the way it's supposed to. So that's what I'm trying. Yeah, that's in the first chapter of the book. I make the case that this was a tightly, intelligently regulated system of just naturally, feeling hungry when you need to, and then just stop, not feeling hungry at a certain point. And that has, for many, many people in the modern world, that has become dysregulated. That is part of metabolic dysfunction. Another term that gets used is metabolic flexibility, which is basically not being able to access your body fat for energy. And
Mm.
so the argument I'm making in that book is that it's not, I really reject the counting calories in, calories out approach. I mean, if it works for people, that's fine, but that's going to be a relatively few number of people that will actually work for. And more people just need to kind of zoom out and, look at ways to improve their general health and restore the kind of natural regulation of hunger and energy expenditure. if that makes sense.
Is that
Yeah.
why you titled all your books Repair? Because it's getting to the core because of how so many of us live in the modern environment and there's a lot of factors we can't control, or even if we try to eliminate a lot of the toxins, etc. But restoring our natural mechanisms of the way our body is supposed to be functioning because it's been in such dysfunction.
Yeah. Yeah. It's
Yeah.
trusting the body. Yeah, I guess that's a good, the repair comes out of just my understanding as a biologist that there is an intelligence in the system, in the biological system that we can't micromanage that. We have to support it and understand that with the right support and removing, whenever possible, obstacles to health, which in this latest book I talk about is various metabolic obstacles, which are sometimes things like medications. Hormonal birth control can be a metabolic obstacle. Removing obstacles, giving the right support, and then the biological system can do what it needs to do. You shouldn't have to micromanage
Mm.
a biological system, which would be the same, which would be periods, menstrual cycles, and it's also metabolism.
I love that. I think it's absolutely essential, for women to get your books, all three of them, um the Period Repair Manual, Hormone Repair Manual, and Metabolism Repair
For
Manual, correct?
women. Yeah, that's
Yeah,
great. Yeah.
I think it's so essential. Is there any last thing? Because besides that, we covered a lot, but there's a
Yep.
lot, even a lot more
Yep.
that everyone can get to diving deeper into all your books. But if we want to just kind of wrap up the conversation here, is there one message that you do want to share that we didn't get to touch on in regards to empowering ourselves about our health?
Yeah. Well, Chris, the thing that comes to mind is the female body is normal. Female physiology is normal. We are not broken. We don't need to fight against or suppress what how female physiology works. I say that as a biologist and also from 30 years of working with patients. It does periods, perimenopause, metabolism. They all respond very well to, in some cases, some quite simple types of treatment. So yeah, I can, yeah, pass that on. And, one of my messages too is to trust your body. And in many cases, it will, do what you need it to do. So, and it's been great. It's been delightful talking to you, all your
Thank
great
you.
questions.
I do have one
Yeah.
last question tradition that I like to ask all of my guests. If you can go back to your younger self, Lara, and pass on just one piece of wisdom to that little girl on anything you'd like to share with her, is there one piece of advice you would share with her?
Yeah, it's a good one. Yeah, that's a nice question to end with. Um, I mean, I guess it's kind of cliche, but like I would say to my young woman, don't worry so much about what other people think. I mean, we all of us, I mean, I think especially any of us who are people pleasers, that can sort of really hold us back, is not wanting to disappoint people or like make people unhappy but the truth is, and I'm sure people have heard this before, most people are not even noticing. I mean, I think so we just have to do what we need to do and accept that people are either going to, support us or probably a lot of the time not even notice. So I don't know if that's helpful, but I think just
No.
say all the brain power I wasted worrying about what other people think. And that's part of menopause too. I like to talk about that in my menopause book. You do get past this after 50. It's like, yeah, it's kind of this like, don't give a F, like
Yeah.
there's an ejection of that, which is, I think that's biological. I think that's built in. I think women in their
Really?
50s and 60s, just that's our birthright. That if we're lucky enough to live long enough, we get to move into that phase of life.
Well,
So
I love it. I've been telling my younger friends in their 30s because I'm in my 40s again, as
yeah.
I mentioned, and I've been feeling like that, like so much more
Hmm.
self-assured of myself, and
Hmm.
I'm not going to waste my time with things that like I don't feel like there's any value in this that's
Yeah.
aligned with my standards, and it's more of a, and it's so freeing and just empowering. So
Mm.
glad to know that's
Yeah.
all an exciting stage of
Yeah.
our
That's ahead of
later years.
that's
Yeah,
ahead
that's
of
what I
you. Yeah.
yeah. Thank you. I just want to acknowledge like how number one, grateful I am that you shared your time with me and my listeners, but just for your commitment
Mm.
to the work that you do. Really, I there hasn't been enough of it, as we've mentioned, and as you know, obviously, dedicated really, really to women's health research and practice and all this information. So I think it's so important, and we're really grateful that you are so passionate about advocating for women's health. So thank you for that. Can
Oh,
you please
thank you.
tell us
Yeah.
where people can connect with you? Where's the best place to find you?
I'm super easy to find. Everything is at larabriden.com. So from there, people can find my books, my 3 books. They can connect to my social media from there, join my newsletter, that's sort of the usual kinds of things. Yeah.
Incredible.
Yeah.
Thank you again, Laura.
All
It
right.
has been an absolute honor to speak with
Great.
you today.
Thank you.